Good afternoon. This is Dr. Larry Brandt, and I'm talking with Dr. Varadarajulu from the University of Birmingham, Alabama, who did a very interesting study in which he took 58 patients and studied the difference between an aspiration needle and a biopsy needle to do fine needle studies of solid pancreatic tumors. We're all used to doing FNA, those of us that do EUS, but now we're talking about fine needle biopsy. So let me start out by asking you, why did you do the study? Why weren't you happy with FNA?
Well, FNAs don't give answers to all of our problems that we have. Some tumors in the pancreas, like a well-differentiated cancer, pancreatic cancer, or if you have a submucosal mass lesion, like a stromal cell tumor, you need better histological architecture. When you perform a cytology, what we get is an aspirate. An aspirate is a juice, and there's only so much you can get out of a juice. You just see cells, whether it is benign or malignant. To get a characterization of the tumor and to know the full morphology, you need a big chunk of tissue, and for that you need a biopsy.
So you really want a core specimen.
That's correct.
So you looked at a 22 gauge aspiration needle, and you looked at a 22 gauge biopsy needle, and if I remember correctly, it said that you had a reverse bevel on that needle. Can you explain what a reverse bevel is?
Well, a reverse bevel is a technology where at the tip of the needle, the grind is reversed. And the reason it is reversed is because rather than a needle going finely into a mass and coming back and forth, the reverse bevel is supposed to cause a friction because the grind is reversed. And that is thought to cut more into tissue effectively and produce a big chunk of tissue for analysis.
Can a histologist tell the difference between a specimen that was taken by a standard bevel needle and a reverse bevel needle?
No, it is not possible. It really depends on the amount of tissue that you can get, and sometimes if you use a large gauge FNA needle, you will get the same histological tissue.
There were studies done using bigger needles, right? 19 gauge needles?
That's correct.
And what was the problem with those?
The problem with the 19 gauge is that when you go through the pylorus, the needles are very difficult to navigate. They are not going to exit the sheath and get you tissue. So when you perform pancreatic body and tail masses with a 19 gauge needle, it works close to about 90% of the time. But when you cross the pylorus, then it works only about 60 to 70% of the time. So the problem is the width of the needle, and that's the reason to make a smaller gauge biopsy needle to make it more technically efficient.
So it was a little too stiff also to pass through?
That is correct. A 19 gauge needle is less flexible.
So you had, I think, 28 patients in each of your groups, and in one group of 28 you did FNA, and the other 28 you did fine needle biopsies. Why did you do the study that way rather than not do fine needle aspirate and fine needle biopsy in each of the 56 patients?
Well, we know from literature that in the pancreas, when you perform biopsies or FNAs, after 7 passes, it's a point of diminishing yield. It's just blood. So if you're going to use a needle that is going to really cut into the tissue, the needle is designed in a way that you're supposed to get a diagnosis in a majority of patients on pass 1 because it's going to cause trauma. So if you're going to perform multiple biopsies using that needle and then you use a FNA needle in the same patient, the yield for FNA is going to be much, much lower, and that will be biased against a study. So the only way to logically do it is to just randomize 2 different sets of patients.
Okay. So did the patients tolerate each procedure equally well?
Pretty much. There were no complications. One patient had a mild pain with the FNA needle that we expect from time to time, and another had a mild attack of pancreatitis, but otherwise no major complications.
Did it make a difference at all whether the tumor was in the head, the body, or the tail of the pancreas?
Not really. A majority of these pancreatic masses, as we know, they are all in the head or uncinate region of the pancreas. And because it's a 22 gauge needle, the needles work pretty much same across both spectrums.
And how about the type of tumor? I know most of the tumors you had were carcinomas. There were a couple of stromal tumors, I think.
That's correct.
Make a difference in the nature of the tumor, whether it gave the same histologic specimen at all?
Well, we got a tissue in most of the patients, but when you looked at the histological core, in about 65 to 70% of the patients, we had a histological core tissue using the FNA needle. And then we had a histological core that was of fairly decent quality using the ProCore needle, but statistically they were all the same.
Now, you're using the term core. Is this really a core? Because to me, a core, when you eject it from the needle, it maintains its shape.
Right.
I would think an aspirate would fall apart. And I'm not sure about a 22 gauge needle biopsy, whether that specimen would maintain its shape or also fall apart. So do you need how do you look at the specimen? Do you need a cytologist on site? And what does the cytologist see? Cells or a core?
In this study, to look at to determine whether it was a core or not, the specimen was not processed on site. Usually, with either needle, they rendered an on-site diagnosis, and then we sent some specimens in cell block, and they took the cell block, and then they examined on the microscope to see if there was really a core tissue available or not. And just by looking at the specimen grossly, it is impossible to say whether it is a core tissue or whether it is a blood clot, because blood clots can look exactly like a core. So the only way to know whether it is a core is to take it to the lab and process it in a different way using hematoxylin and eosin staining, not the conventional diffquick stain. And when you do that, you get a better assessment of morphology, and that's the way to say whether it is core or not.
And was it a core or not?
Well, as I told you, in about 100% of the patients, when we did the FNA, there was something called a core tissue. And then in about 80% of the patients, when we used the core needle, we had a core tissue. So in fact, the FNA needle gave us a core tissue more than a core biopsy needle. But it is not enough if it is just a core tissue. As you rightly said, if the caliber of the needle is small, it may not be a good core. So we graded the core tissue into optimal and suboptimal quality. The amount of optimal quality using a ProCore was about 80%. And the amount of optimal quality using a FNA needle was about 67%. Not statistically significant, but the amount of good quality core was a little better with a ProCore needle.
So having said that, what do you think standard practice should be now? Is this core biopsy needle something that should be used preferentially in patients, or should the aspirate that most people are familiar with be used?
Well, the advantage of an aspirate is that most patients, when they come to us, their expectation is they need an answer before they leave. And the reason is because we have a pathologist in the room who will process a specimen. You've got a very efficient diagnosis. Patients come from a long distance. Once they come to us, they want to go see the surgeon the same day and so on. If you're going to use a biopsy needle, they're not going to get an answer for a day or two. So I think that is the real advantage of EUS. My own take would be that we should continue to use the EUS FNA needle for a majority of procedures. One, because it is very efficient. Two, it is less costly. The ProCore needle, just because of the technology involved, is more expensive, and there's a delay in diagnosis. But there is a niche role for this needle. In patients in whom there's a history of metastatic cancer, they've got a past history of cancer, and we really don't know whether the mass in the pancreas is a primary pancreatic cancer, or if it is a malignant tumor, or if it is a well-differentiated tumor, or if they had a failed biopsy before. Those are the circumstances we should use a ProCore biopsy needle. But otherwise, I think FNA needle should be the standard of care.
Can you extrapolate, and I'll ask you about something that you didn't study, which is use of the core needle in biopsying, let's say, lymph nodes?
Not actually. There's not much, because very often when we look at lymph nodes, we are primarily looking for metastatic cancer. So it is either benign or malignant. And for a lymph node, the conventional FNA needle will do the job. Unless you're looking for a lymphoma. If you're looking for a lymphoma in a lymph node, then they're going to ask for flow cytometry. And numerous studies have shown that for flow cytometry, core tissue is much better than getting a cytological aspirate.
That's a very good point. So that actually takes care of all of my questions. Give me your bottom line, the take-home message for the listeners to this, and then we'll call it a day.
For a conventional FNA, I think one should just continue to continue their practice of using a regular fine needle aspiration product for all the biopsies. There is a role for the core biopsy needle. As I had said earlier, this should be in patients who had a previous FNA in which you did not establish a diagnosis, or in a patient with special lesions like a neuroendocrine tumor, rare cancers, metastatic cancers, and so on, in which your FNA may be indeterminate. You should use a core biopsy. And finally, more and more cancer treatment is molecular based. Say, for example, if you've got a patient with a breast cancer and there's a mass in the pancreas, in breast cancer, all the treatment is molecular based treatment. And molecular based treatment requires core tissue for pathological assessment. In those patients, again, you will require a pro-core needle. Having said that, 95% of the time, you just need a FNA needle to do your job.
Well, you used the word finally, and to me, finally is the end. So let me thank you very much for your expertise, and let me wish everybody a good day. Thank you.